All right, now we're starting. So first, now that we're recording, I need each person to stand up, show the camera. I have to have at least 4 people. There's 1, there's 2, 3. All right, there's my 4. Good. Okay, so we're going to do demonstration training on how to intubate an unconscious patient. I'm going to go through all these materials. Here's a course outline for you guys. There you go. I got 4 of those. You can pass those out. So this outline is going to, let's see, oh, you got it. Perfect. So this course outline is going to cover the objectives of the class, all the materials that we need. And today what we want to do is we're going to identify all the different materials, and we're going to explain, I'm going to explain the steps that you would take, and then I'm going to perform them. And then you guys are going to actually come up here and do the skill yourself. So first to start out, we're going to have our equipment. We have to have our safety stuff, so at least protective eyewear. We've got gloves, so we're going to put gloves and eyewear on. After that, we have a BVM, an adult BVM. We have our Zoll monitor, our suction, our end-tidal, and our OPA. We've got our innovation handle, and then our blades. So we've got Mac 3, Mac 4, and then we've got our 3 Miller blades here, so Miller 2, 3, and 4. You guys can choose whatever one that you'd like to use when you come up here. My preference is the Mac 3. I think that makes it the easiest to intubate this patient. We have a 7.0 endotracheal tube. We could normally when you get ready to intubate, it's good to have the one you think you need, the size below and the size above. So if you try to attempt to intubate and you find out it's too big, you have both sizes both ways. You need a 10 cc syringe to pump air into the balloon on the tube. So make sure it's all out. So when you hook this up, you're going to put 10 cc's of air in it. Then after you get it in, just go ahead and put 10 cc's of air into the tube, and that'll secure it. And then we have our Thomas tube tamer to secure the tube to the patient. After we intubate, we have to confirm per our protocol, which I also have printed out for you. Per our protocol, we have to have at least 2 different ways to confirm that our tube is in the right placement after we get the intubation done. So it could be listening to it, listening to breath sounds, or using end-tidal. So you hook your end-tidal up, make sure you have end-tidal wave capnography, and listen. And through this, if you guys have any questions, just worry about it. This is, again, you don't have to not talk. So,
does chest rise count?
Visual chest rise can count, yes. And also what can count is the visualization of the vocal cords and watching the tube pass through the vocal cords. So that can be one, and then you can listen, you can watch it, and then use end-tidal and stuff like that. All right, the different blades, the Mac blade and the Miller blade, work in 2 different ways. So with the Miller blade, the straight one, we are going to completely scoop the molecula and lift up to expose the vocal cords. All right. So when you have the molecula, there's a little flap that hangs down in front of the airway. That's what's going to go back and forth to determine, like, is there air going in the airway, food going down the esophagus. So with this one, that little flap is going to hang down like this, and the trachea is going to be right here. So with the Miller, you're going to go all the way under, and you're going to scoop it like that and pick it up to expose the airway. With the Miller, it's going to be, you're not going to try to scoop the molecula. You're actually, with the Miller, you're going to the void space right here from the mouth that comes in to the vallecula, you're gonna stick this in that hole and then use this to pickle it up by putting slight pressure forward, and that's gonna cause that vallecula to wanna come out. So with the Miller, you're gonna fully scoop it. With this one, you're gonna not, okay? So after we start our innovation, or before we start our innovation, we want to hyperventilate our patient with a BVM. So we're gonna hook up to high flow oxygen. We're gonna try to hyperventilate first, or we're gonna hyperventilate our patient, and then when you're ready, we'll set it down, start with the tube. I typically would use with our new BVMs, it works a lot better now because they're adjusted, or you can adjust them. But normally I would use like a pediatric size or a child size airway. Why that? Why would I use a child airway instead of an adult one?
Because if you squeeze the full size adult, then you potentially will be giving a lot more air than they actually need. A lot of adults are only in that 400 or 500 pound volume range.
Exactly. So a lot of times within a full adult, this is a 750 mil bag. When people would ventilate and they would squeeze this bag all the way, you reach max tidal volume in the patient's lungs before you're done squeezing, and then the rest of that air goes in the esophagus. We create air in the esophagus. When we create air in the stomach, then what do they do? Exactly, they throw up. And you get emesis everywhere, gets in your airway, they aspirate, bad news. The good thing with these new BVMs is that's why they're regulated. So when you squeeze, it takes more time for them to fill up. So then it's harder for you to overventilate a patient because this is only going to fill up for you to breathe once every 6 seconds. Okay, so I'm going to demonstrate the whole skill beginning to end, and then I'm going to let you guys come up here and you guys are going to actually go through it. And I'll be up here and I can help you guys along the way too. So, PSI scene safe first.
Are there any contraindications?
To innovation?
Yes.
Yes, there is. So the contraindications is if we have trauma to the airway or to the face, if we have bone structure manipulation from trauma that we aren't able to safely get the airway or see the airway. Let's see, if they have a gag reflex, you're not going to want to intubate. Maybe another one. Okay, so I got my bag hooked up to my oxygen. I'm going to insert my OPA first by hooking the corner of the mouth and turning, just like that. I'm going to assist my partner or whoever is assisting you while you're preparing for intubation to breathe for me with the BVM to hyperventilate the patient. The whole time that we're getting ready, or as you're setting yourself up to intubate, you want to try to maintain sterility, make sure everything stays clean. So I'm going to get my handle ready. I'm going to connect this to my tube. I would have somebody hand this to me when I was ready for it, whoever's assisting me right now breathing. And then I would have this ready. All right, so now that I'm set up to intubate, I'm going to hyperventilate, which doesn't mean breathe faster. It just means give them enough adequate breaths to increase their SpO2. A lot of people think that if a medic says, hey, hyperventilate the patient, I'm going to intubate, that means they got to sit here and go like this and breathe super fast. That's not the case. That's not hyperventilating. You just want to give them 6, 7, 8 really good, long, deep breaths. While we're hyperventilating, there's a couple ways that you can have somebody assist you in with a tough airway. So one of the ways that we can do it is we can ramp up the patient's shoulders. So when we ramp up the patient's shoulders, it drops their head, making more of an inline shot to their airway. It straightens that airway tract out. Instead of being a curve, it gets it more in line. The other part is you can have your partner give cricoid pressure. So you guys have seen you're going to push right here in the cricothyroid membrane, push that down, and that's also going to bring that bend out of it. Okay, so we've hyperventilated the patient. We're going to remove our airway. Now we're going to insert our laryngoscope into the proper spot to expose the cords. You're probably going to have to drop your head a little bit to see the cords. This airway, like I said, is pretty tough. So I can visualize the cords, and I'm going to insert. I'm going to note the spot on the teeth where I'm at, and I'm going to secure that too with my hands at the mouth. We're going to pull our stylet out. We're going to inflate our balloon. There we go. There we go. Go from our BDM, we'll start to breathe. So, if we insert the tube and we only see one lung inflating, what does that mean we did? Sure. So if we push this down a little farther, see how only one lung is inflating?
Yeah,
What does that mean?
I would think that they would have a collapsed lung.
Okay.
Or
Joel?
maybe it's
Or
too,
not, Hunter, sorry.
maybe it's too far down in the bronchial.
There you go. Yeah.
So you pull it out just a little bit and then it'll get
There you go. Perfect.
why.
Yep. So when we insert the tube in our airway, it splits. Okay. We're gonna go left lung, right? The right lung is more in line than the left lung that more tees off of the main airway. So when we insert our tube, if you go too deep, you're gonna go what's called a right main stem, which is you're only inflating the right lung. That's how you're gonna get that. That's how you're gonna get that just one lung. So all you have to do is carefully pull that tube back out until you get to the top of the carina, and you're gonna be able to see. You're gonna be able to see that both lungs are now inflated. All right. So the main thing is to make sure that you don't let go of the tube until you've got it secured. So somebody needs to make sure they have this tube or their hand that's going to secure this tube to the lips so it doesn't move, so we stay in that first spot. But at this point, I either have my partner or whoever's assisting me with it get the tube timber put in place, and then have them bag while I did it. So I would have my partner bag, and then as we come through here, with our tube timber, we're gonna wrap it around here. We're gonna bring it up, place it in the mouth. And then we're gonna tighten this down. Tight. And we'll come up through the slot. And secure it that way. After we've secured the airway, one of the most important parts is we've got to check for, we have to confirm our airway's in place. So I would have my partner breathe for me. And when you guys come up here, I'll be your partner to assist you guys. So we're gonna listen. We'll listen for long sounds. If we have good long sounds, then we'll hook up our end-tidal capnography to our monitor and check our waveform. After that, we've confirmed it, your airway's secure, and you're good to breathe. All right, does anybody have any questions about any of those steps?
Can you put capnography on the BVM before you do that, just so it's ready to go once you?
Absolutely, yeah. To pre-stack, if you want to pre-stack your tube, you can. The only thing I would say with our capnographies here is if you break this seal of this bag, technically it's not sterile anymore. So I would be careful about, doing that. But if, as the event happens, like as you're preparing, say you're on the mask, if you want to go ahead and put it on there at the beginning of the code, like before you need it, absolutely, 100%. There you go.
What are we looking for on the monitor for capnography to confirm placement?
So in your waveform of your capnography, we're gonna see, do we have a number reading? We wanna be between 30 and 40, I believe. But do we have a reading? What is our reading? If we have some sort of number, we just wanna get some sort of response. Whether that's 50, it could be 70, it could be 10, depending on, what your readings are. But if you just get a flat line and you're not getting any sort of carbon dioxide reading in there, and that means you're probably in the stomach. If you have a missed airway and you see the stomach starting to rise, obviously you missed your airway, you're in the esophagus. Okay? All right. Who would like to go first? Hey, Oxford, will you grab some more tape and help Captain?
What is condensation in the airway mean? Is that an indicator of anything?
It is. So condensation in the airway is going to show that you have air exchange in the lungs. So the inside of the lungs is super wet. You have a lot of moisture in there. So when you breathe, it comes back up because it's hot air, right? So when that hot air comes back up, it's going to create a steam. And that could be an indicator that tells you that, hey, I've got good placement in the lungs.
Usually go Mac 4, but I'm gonna try Mac 3 on this guy.
Yeah. So it's not like
If you go too deep and you go into the right side lung, do you have to deflate that to move it at all, or?
I would, so you don't cause trauma to the airway. Right. So I'll be your assistant. I'll do anything you ask me to, but
Okay.
just go through the whole steps from just walk there to the airway to intubated and secure.
Yep, I'll go ahead and go getting started. I'll have you take over the airway.
Okay.
All right, hyperventilate the patient for 6 to 7 breaths.
There you go.
Medic 1, Merchant Medic 3, medical engine, medical arm, 743 leading entry, 743
Yeah.
Keep on going?
No, we'll keep going. I'll have
Yeah.
somebody else come up here.
Alright, I usually go 4. I'm gonna try 3 on this one too.
Yes, I see.
Alright, looks like we have all of our materials here. Okay.
We're gonna bag them, hyperventilate.
Medical 3 for medical alarm, 743 leading entry, 743
Deal?
Good.
All right. Can you see it?
Mm-hmm.
Cool. Well, hold on, get this. Thank you.
So that means we went too far, or just wrong?
So
So I got the flap.
Yep, so if I can, let's see. So if you pull your airway back a little bit, do we have any air movement into the lungs?
Mm.
Yeah, okay. So you can just see your airway, so go ahead and pull your airway out. There we go.
So I didn't actually see the chords, I guess.
Okay. So let's try it again. You might have been a little bit too deep with your blade. There you go, really good.
Oh, okay. Now I
See it now?
Now I see it.
Beautiful. There we go. I can bend your tube if I need to. So these tubes get real sticky and they don't really want to slide in there.
Can I give him correct pressure?
Sure. We need to. Got it? Did you see him?
Yeah.
Okay, I think we're in the stomach still. So here, I'm gonna show, when you saw the chords, what did you see?
Well, maybe I didn't actually see the chords.
So here, I'm gonna go in there and I'm gonna show you.
Can I look too?
Yeah, absolutely, everybody can. All right. So do you see that? It looks like
Uh-huh. Yeah.
see that? That's the hole you're shooting
Let me look.
Kind of looks like anatomy.
for. Yeah, like an athlete.
Oh, that's not very big.
So you have to pull back a lot more, I thought.
Yeah, so when you get the control of that tongue, you see the flap in there?
Mhm.
That's the molecular. You want to be right on top of that, and then as you kind of pull up, that's going to expose those cords, okay?
Yep.
There you go, try again. There we go. I'll bring you this back. See it?
Yes.
Okay, maybe see.
There we go. That's much better.
Yeah, well, there we are. All right.
One lung.
There you go. There you go. Now we got two. All right, so you're gonna keep holding that secure, right?
Mm-hmm. So we've got the chest rise. chest rise,
And then you
listen to breath sounds, and then
Okay.
check my end tidal.
can
and
entitle.
confirm that
And
later
you
on.
don't have to actually listen, because we can see it.
So what confused me, one question I had was you said that with this, you actually go under,
Yep,
with Miller, you go under the flap, right?
Correct.
But then
Yep.
the Max, you don't go under?
nope. So, you saw that flap hanging down, right? When you come in with this Mac blade, you wanna hit right on top of it,
Uh-huh.
and then when you push, it's gonna pull that molecule up. Where the Miller, you're actually gonna scoop the whole thing and pull up, like
Right.
that, okay? That's the way the two blades work a little bit different.
Oh, okay, but, so the blade should never go past the flap? Plastic?
Not the Mac.
Okay.
The Miller will go past it a little bit when you pick
keep
it
it
up.
up.
Yeah, to
Okay,
keep
that
it
makes
up.
sense now.
The Mac is a little bit wider, so it's a lot easier. The biggest issue people run into is they have trouble controlling the tongue. The tongue wants to flop around it and it'll obstruct your view. So having that wider blade on the Mac actually helps you get control of that tongue a little bit more. To then get down to see your molecula and get in the right spot.
Is this pretty close to being anatomically like accurate? Because if you go just too far, it gets into that.
It can, absolutely, yeah. The carina at the top of the airway is super, like when you go in, you've only got maybe an inch or two to play with in there, probably like an inch, to where you're too far back, too far, or too far forward. So,
That's good.
Alright, you ready? I'm gonna give this thing a little bit, little spritzers. Yeah, a little spritzer.
Some Banaka.
Okay. Alright.
Where do we put the OPA at?
Find it.
I did not.
This fell off with that.
Maybe it went to me.
Oh, yeah, it could be.
Oh, got it right here.
Oh, alright. We'll pretend that was there on the phone.
Get a new one?
Yeah.
Side. Leave one here.
Let's go first. Oh, here it is. Give it a little too.
We're gonna hyperventilate for about 4 to 6 breaths. My assistant can do this as I set up. Maintain the seal.
So in a perfect real life scenario, would you see the vocal cords? Is that the vocal?
You should. If you have a really tough airway, you should never innovate blind to where it's like you think you know who the cords are, you just can't see them. At that point, you'd want to go to like a video scope and see them that way, if you weren't able to see it with the manual vision.
All right, when you're ready.
Okay.
I'm ready.
All right.
I'm gonna crank that soldier boy.
2 clicks, you're almost there.
I don't know if I should know what This guy's.
What do you see?
One-sided dog. And can you put a bend in that,
Sure.
please?
Good. Perfect. Looks like you're blue.
Can you maintain air?
Yep.
All right, and we can oscillate for lung sounds.
Okay.
We can hook up our capnography for waveform on the monitor. Or we can see chest rise and fall.
Awesome. Good job.
Show.
Best part is you have your safety readers on.
Yep.
So do you know if you only have one lung, like would the end tidal be like quite a bit less or?
You would see a difference, yeah. Yeah, you would see a difference. You would probably have a lower end tidal just because of one lung. You've only got half the oxygen exchange that you normally would have.
There's so much.
So the biggest thing is like, so now let's say you have a tension pneumo on the left side. You know, what could you do to fix that? If you just put an iGel in and you breathe, what are you gonna do? Make the issue worse, right? Now, with a tension pneumo, we're going to needle decompress the chest and we're gonna get that. But if they're unresponsive and you intubate them and you're breathing air into it, you're just gonna keep creating the problem, right? So if they have a tension pneumo on the left, you might want to bury that tube and go right main stem. To where if they have a, you know, right lung injury, or say they don't have a right lung, you're gonna maybe wanna stay a little bit more shallow to make sure we're capturing that. Okay. All right, who's next? Matt, you want to continue?
You shall. I get a call this time, no, I'm not going.
So you can edit now where you were.
Yeah.
No, you start from scratch.
All right, so you want to go ahead and do the OPA and start before we get into it.
Do that. Fully expect like a real good TikTok edit to make this video look cool.
Yeah.
So we don't have to view my first two fails straight to the success.
Yeah, just continue on to your patients. Alright, once you've delivered some consistent breaths, I will switch over. You can take that OPA out and I'll get everything set up and kind of it.
Good?
Yep.
All right.
Debrief for me, I'll secure the tooth down. I'll sit alongside, set up tip counter feed, head visualization of chords.
Good. Perfect. All right, Samuel.
Alright.
Have you put in the OPA, please?
Sure.
And BBM on. Set this up. PSI scene safety glasses here. Okay, have you hyperventilate the patient for me? 4 to 6 breaths. All right, here we go. Have you ventilate again for me? I just think I need a more curved blade on this.
All right, man, thank you.
Give him 4 to 6 breaths, and we're gonna try again. No, we're ready. We're good. Can I get some pressure, crackle pressure?
Yeah, ready?
Yep. That's not helping, sorry.
I think you're a little too deep.
A little bit.
Trying to get above that blood,
Can you see the flap?
Can,
You what?
can now, but I can't see the chords.
Okay.
I feel like if I'm like, yeah, I'm gonna have to use the flat blade.
So, here.
So I would have you ventilate again, but
Okay, so real quick.
I'm having trouble with this blade.
Yeah, so real quick. On this one, I think you were way too deep.
Even with the short one?
Yeah, so if you take a look again, so you can see right here, the spot you want to be in, see how far my blade's in? You were in super deep. Yeah, you were clearing here, so you were getting so deep that you were picking that whole airway and pushing it back.
Okay.
So when you
So
see
you see it right there?
yeah, so I'm gonna have you come in on the side.
Okay.
Can you see it?
Yep.
It looks like anatomy.
Yep.
Gotcha. Yep, so that's what you're looking for.
Okay.
go. And a lot of times, if you start high and you just kind of keep creeping your way low until you finally get that right exposure to where you can pull up and see, that's normally the best way. Or if you do go a little bit deeper and then you kind of just work your way back, whatever way you do it, you just kind of got to shift back and forth a little bit.
Mhm.
Try to-
I might have missed. Well,
Okay, so we're,
Do you need to inflate the balloon?
oh yeah, right here. Yep,
no.
Just probably using there that bad.
yeah, there you go. So now we're-
Paramedic show coming through.
So now try.
Oh, yeah. So, I mean,
Oh, yeah,
Wrong
okay.
way.
Yeah,
Okay.
so
Maybe
let's
gas
start.
it.
So let's take that off. We'll deflate your balloon. Let's try again.
All right.
Oh, there we go.
it's okay, Campbell, it happened to me twice.
All right.
All right, so I'm gonna switch blades.
Okay.
Try with a different one. So I'd have you ventilate again.
Okay.
I'll just say we had you ventilate again, and now got my tube ready, got everything ready. This time. Let me see it. Let's see if I-
When you're in, that tube will stay up to the top with the blade.
Still, no.
Like there's a big difference between going into the stomach and then when you actually were in there, it stayed up
Yeah, it
higher.
stayed up when you pushed it in, yeah.
Like that,
A little too deep. Creep it back.
So you have them deflate so they don't creep it.
Okay. There you go.
There you go. All right.
Okay. I'll have you ventilate.
Got it?
Yeah, I think that flash blade is a lot easier.
A lot easier. And yeah, different, people prefer different blades.
Okay.
All right, how would you prefer?
I'm gonna use the stethoscope to check bilateral press downs.
Okay.
And then hook up capnography to get a CO reading, 35 to 45. And then I could also check, make sure I got equal chest rise.
Good.
Okay.
Do that. All right, 1, 2, 3, 4, y'all did it? Okay. So, does anybody have any questions over innovation? Does everybody feel like they can safely and adequately innovate an unconscious patient?
Yes,
Yes.
All right,
we do.
there we go. Perfect, so I'm going to give you a evaluation. So you guys have to fill these out. Thank you. And then I have student competency evaluation to make sure that you hit all your steps. So I'll fill these out and sign them. And then we have to, oh yeah, and we're also gonna sign this roster, saying that we're here. And that's it.
No quiz today?
Huh?
No quiz today? Or that was our quiz?
This was the quiz. You passed.
All right.
Everybody passes. Alright.
Are you handing these in?
Yeah, I've actually gotta turn those in.